So today I'm really excited to have Dr. Bemberg on with us, and Geri Beth is a doctorate in pharmacy, and she works for Stevens Insurance, and Stevens is a UBA partner, United Benefit Advisors, so partner with Relational Advisors, and welcome, glad to have you.
Thanks, Mike, glad to be here.
Yeah, thanks so much. So today we're going to peel back the layers of the onion a little bit on pharmacy spend in the U.S., and particularly how it's impacting employers and participants alike. I was just looking, I think in 2023, the pharmacy spend in the U.S. was just under $800 billion, which is a staggering number, and breaks down to about $1,500 per capita, which is, quite amazing. When I think back my childhood and look at my dad's, pharmacy cabinet in the bathroom, there was aspirin, and that was about it, But today we open it up and there's a whole, cornucopia of little orange bottles in there. So when we look at it from the employer standpoint, there's so many things that can be done there, but sometimes it does feel overwhelming. But tell me, Geri Beth, so tell me a little bit about your story and how did you, your journey, and how did you get to where you are today?
Yeah, absolutely. So I went to pharmacy school like most do. I didn't really know what I wanted to do. I thought maybe clinical might be the route for me, maybe in a hospital setting. But I did a rotation. My first, you do rotations throughout pharmacy school in your last year. And that rotation, they worked through insurance plans, specifically the state of Arkansas, school teacher and state employees benefits. And they manage the formulary for that insurance plan. Now, I'm not talking about a couple hundred lives, a couple thousand lives. This group was 150,000 lives. So you're impacting, in Arkansas at least, a large majority of the population in a self-funded arrangement. And I realized very quickly what I was wanting to do was to do that in other health plans. So I actually did a residency in evidence-based medicine and managed care pharmacy, which is essentially just a fancy way to say I now specialize in what you should cover, why you should cover it, and then also how you should cover it through your pharmacy benefit manager relationship. Mm-hmm. Prior to coming to Stevens, I continued to do that through mostly state self-funded plans. Mm-hmm. And then I was recruited by Stevens about 7 years ago to come do that for their clients. And so now, we've built quite the pharmacy practice, myself and another pharmacist, Dr. David Kiesner, and we are having so much fun doing it. And because of our relationship here and Stevens' relationship with UBA, we are now able to work with other partner firms such as you guys, and we are able to now be the UBA Alliance Preferred Pharmacy Vendor starting in 2025 with COEO. So we're super excited and glad to be here.
Yeah, we're very excited about it as well. And in fact, at our last UBA meeting, that's really what triggered the desire to interview you a little further and then get a better understanding of not only the offering, but some of the best practices that both employers and even participants can do as consumers, to help kind of manage the cost. And one of the things when we look at least, in the last 12, 18 months of one of the significant cost drivers is the, wide and mass distribution of the GLP-1s or the Wegovy's and Mounjaros. Can you talk to me a little bit about, those drugs, not only what they do, but then the impact to employer health plans and to participants?
Yeah, absolutely. I think to look at those products on a weight loss benefit, you kind of have to take a step back a little bit, right? So most people are familiar with GLPs more on the diabetes side. I mean, familiar with a couple of years ago on the diabetes side. Now everybody relates them to weight loss.
Sure.
Thanks to social media, mainstream media. You get on the internet now, it's the first thing you see usually. But those products such as Ozempic, Mounjaro, Trulicity, Victoza, they were traditionally used to treat diabetics. Mm-hmm. Victoza is actually the first product that came out with a weight loss drug. It was called Saxenda. It came out, goodness, probably 8 to 10 years ago. But the thing that was interesting about it, there was not that large uptake that we're seeing now. And I directly attribute that to the fact you had to take it once a day. Mm-hmm. So, mostly why most diabetics did not want to take these GLP products in the past is because you didn't want to take a shot every single day. And
Yep.
so now these newer products are once a week. And then you can see now they have these weight loss benefits. And so that's how we got Wegovy and Zepbound. So Wegovy is that weight loss version of Ozempic, and then Zepbound is the weight loss version of Mounjaro. But you're exactly right. I mean, these drugs are driving healthcare expenditure in ways, I mean, I would hate to say that we haven't seen before, but it's really the first time we've seen the media and social media playing such a large role
Yes.
in the medications people are asking their physician for.
Mm-hmm.
And it's having a big impact on the healthcare plan overall. So just some walking around numbers to think through. So a 1% increase in utilization of GLP products actually drives a 5% increase in overall self-funded employer healthcare expenditure, which then accumulates
that is
to
significant.
about a 10. Yeah, absolutely. It's a big number when you think about it. I mean, you think through what some of your employers and some clients are spending on healthcare, 5% is a big number. And then when you put it into that per member per month number, and that actually comes out to about a $10 PM increase just from the addition of one drug category. That's something we haven't seen in a long time since specialty drugs really came onto the market.
Right, right. And I know that just in looking at some of the the prescription reporting from the carriers that we see in PBMs, I mean, it might be that 6 of the top 10 drugs being dispensed now are in the GLP-1 category. You're right. I haven't seen anything like it in 20 years, 30 years.
Yeah, and it's interesting to me. I think semaglutide, which is the generic name of Ozempic and Wegovy, it was very close to being the number one product, or may have been the number one if you just look at active ingredient products. That was a cost driver in the U.S. last year. So, a little less than $800 billion spent in the pharmaceutical industry, and semaglutide and adalimumab, so, the generic name for Humira, those were the two heavy drivers there. Semaglutide being made up again of Wegovy and Ozempic, but adalimumab, we have all these biosimilars out in the market for it now, and Humira is still finding a way to have some market share there.
For sure. Yeah, that's interesting that you mentioned Humira because, thinking back over the last 4, 5, 6 years, so beyond the GLP-1, that was really one of the bigger cost drivers, just in and of itself was Humira.
Absolutely. And now, the biosimilar world that we're in, so, for anybody who's not familiar with that, a biosimilar is essentially a generic version of a biologic product. So they're not going to call it a generic, but it has a brand name in most instances, but it's that same active ingredient. They've been approved for a little bit, but they've been tied up in litigation as well here in the U.S., and so we're starting to see them hit the market. As more and more enter the market, we're going to hopefully see them drive the cost down overall. But, I mean, when you look at a drug that has, I think, 35 to 40 indications, it's treating a whole host of different disease states. It is making still a large portion of the healthcare expenditure in the U.S. And then you think about, too, there are several other drugs just like it. I mean, you've got Enbrel, and then you have the Stelara and the Skyrizis of the world, so you take them less frequently, but they still cost the same on an annual basis. It's interesting, and it's having a big impact, honestly, on the drugs that are approved through the FDA on an annual basis. One thing I've noticed is that over the years, we've gone from the FDA primarily focusing on approving new blood pressure meds or new cholesterol medications or things such as that. And now we're at a place where they're approving, I think it was like 14 biosimilars were approved in the first half of 2024 this year. So they referenced a whole different host of products. So we were looking at things such as Stelara and Humira, Solaris, things like that. And so we're heavily, approving specialty meds, which are more expensive. And so it's just driving up healthcare even further.
And talking about, potentially, prices coming down with the biosimilars, once hopefully they get through litigation here and are able to get to market. But I've also been reading about some price wars starting to happen on the GLP-1 side. There's an article in the Wall Street Journal the other day talking about that. So do we think there might be some relief for employers as these prices go down, or will it simply just spur more demand so that the net spend, I don't know, will be that much different?
No, I think that's a great question, honestly. They have kind of gone an interesting route with that. So, Eli Lilly makes Zepbound and Mounjaro, and so Wegovy, though, is the product currently. It's made by Novo. They really have more indications they're getting approved for. So they have the secondary cardiovascular risk reduction indication that was approved. So Wegovy can be used for weight loss. It can also be used for secondary cardiovascular risk reduction, which is a fancy way to say if you've had a heart attack or a stroke, you can take this medication and it will hopefully prevent you from having another.
Yeah.
And it has been shown to work in clinical trials. But I say that because it's interesting. Eli Lilly has really taken the stance of this kind of direct-to-consumer avenue that I think was referenced in that Wall Street Journal article.
Yep.
So what they're doing is, for a cheaper price, much cheaper than what you would actually obtain, in a pharmacy, you can go to their website and you can get the medication through a prescriber, and you can get it directly from the manufacturer for, I think, like $400 a month. Now, it is dosed a little bit differently. You have to draw it up yourself in a syringe and inject it. It's not in a pen. But that is very interesting to me because they're trying to get their market share in a bit of a unique way.
Yep.
For Wegovy, the rebates really come into play there, honestly, right? Because that's really what's going to, at this point in time, drive the cost down. I don't foresee either of those drug companies actually lowering the cost of their medication just right off the bat. It'll have to come in the form of rebates, which actually makes our job even more important, though, because it really hammers home the need for that really strong, transparent pharmacy benefit manager contract to ensure if you are self-funded, that you're getting your rebate. So, they may raise the rebates, but if you're not in an arrangement where you're going to benefit from that and your plan's not going to benefit from that, that's not really helping anybody. But yeah, it's an interesting place we're in right now, where in the past we've kind of toyed with the idea of savings in the sense of formulary control, right? Let's move something from tier 3 to 2, or it'll go generic. We've entered a whole new world now where here come direct from the manufacturer shipped to your house at a cheaper price, which plays outside of your health benefits.
That's right.
So it's very interesting, though.
Yeah. So a couple of things I want to drill down on. One that you just mentioned is the topic of rebates, and I think that most CFOs are certainly aware. Probably in the smaller end of the market, under 100 employees or so, it's difficult to, unless you're truly in a self-funded environment, it's difficult to take advantage of that. But at a higher level, I always think of a rebate like, an automobile manufacturer. Okay, well, the price of the car is, $60,000, and then they're going to give you $5,000 back. But can you walk us through sort of the mechanics of the rebate, and then where does that money go if you're not paying attention to it?
Yeah, absolutely. So it's interesting you say the sticker price on a car. David and I have a joke. So, drugs are priced off AWP. And so we say AWP, it normally stands for average wholesale price. Here in the South, we also refer to that as ain't what's paid. We oftentimes say it's like the sticker price on a car. You should never pay it.
Right, your MSRP.
Negotiated. Yeah, exactly. You never walk in and pay that. But you're exactly right. And so the way rebates work is drug manufacturers will negotiate with a pharmacy benefit manager. So, just for reference, in this instance, a pharmacy benefit manager, or a PBM for short, those are going to be companies that manage actual pharmacy benefits. So they adjudicate the claim. Commonly known names are people like Optum, Express Scripts, CVS Caremark.
Yep.
So those companies negotiate on behalf of their groups that they represent, so employers, with drug manufacturers for a place on their formulary. And so in exchange, in a very simplified version, they provide rebates back to the PBM in exchange for placement on the formulary.
They dangle a little
Now,
carrot there. Yeah. That turns out to be not so
absolutely.
little. Yeah.
Yeah, and it actually turns out to be almost 40 to 50% of healthcare expenditure, honestly. And that's the part that you really got to watch out for, though, because exactly like what you just said, where does the money go if you're not in a self-funded arrangement where you're getting 100% of the rebate? Where does the money go? And it does go back to the PBM. In a fully insured arrangement, oftentimes it's used to offset price hikes and premiums and things like that. So there's a lot of different places it could go, but I will tell you, in a self-funded environment, if you have that transparent contract, it's going back to the employer. You just have to make sure you put yourself in a place where that is the case, so you and your plan can actually benefit from it. Now, in a fully insured arrangement, that's something that more and more as rebates have gone up, I think employers, even in a fully insured arrangement, have to be more aware of rebates than they ever have before.
Absolutely.
And the reason I say that, yeah, absolutely. I mean, you see time and time again that PBMs and carriers will come back with a price hike, or, we're going to raise rates 10%. And
right.
It's like, well, guys.
Right, but there's $100,000 or $200,000 that's being funneled back to the plan. That's just, it doesn't show up as an offset to the claims, which it really should.
Exactly. Yeah, absolutely. And so that is something that we're doing for employers now, is looking at pharmacy spend, even on fully insured clients.
And you can project what estimated rebates are going to be within that plan. That's really powerful information.
Yeah, absolutely. And we've had several clients that have gotten rate holds out of that. They've been able to negotiate. If they truly did deserve an increase, if they had a bad year, they've been able to negotiate that rate increase down.
Yep.
It's just having, I hate to say the knowledge is power thing, but that really is where we are in terms of rebates.
Yep. So like in that kind of an example, let's say I'm an employer and I have 200 employees. Maybe I am fully insured. That just it's different market by market, right? And so especially in California, where you have a lot of HMO population, you might have 150 folks on the HMO and 50 on a PPO, and doesn't always necessarily lend itself to self-funding, but in that scenario, if that employer can get a list of the top 10 or even top drug utilization from the carrier, then you guys can look at that and do a projection of what that rebate amount might be, or a range anyway.
Yeah, absolutely. Because it's funny you say even just the top 10, because you hit the nail on the head right there. When you look at a pharmacy spend at this point in time, top 10 usually is 50% or more of their plan spend. So that's where the rebates are anyway. They're always your higher cost meds. They're always those brand name diabetic meds like we just talked about. The other categories that may pop in there, so the oral anticoagulants. So,
yes.
Those are almost always brand name. Inhalers oftentimes pop up, and then mental health medications as well. So brand name depression or things like that. All of those have a rebate. And so we've had tremendous success, using just the top 10 to help our clients, look at their overall spend, forecast what those rebates should be and what they should be getting credit for, and then kind of use that to help get them either a rate reduction, rate hold, or get that increase down a little bit.
Right, right. And so I do want to talk a little bit about, the participant, like we as consumers, and some of the things that we can do. But before we get to that, maybe share just a little snapshot of like some of the different exercises that you go through to help an employer not only become aware of their spend, but then start to pull some of the levers of what they can do about it. Let's say in that employer that's in the 100 to 500 employee range.
Yeah, absolutely. So, obviously it's another area where even 100 to 500 lives right there, right? We're talking about if you're fully insured or self-funded. So fully insured, you're more reliant upon your carrier,
Yeah,
obviously.
because that
So you're
PBM is
looking at
tucked in.
things.
Yep.
Yeah, absolutely. So you're relying on things such as, how can we fluctuate our copays? Do we need to look at moving to a deductible plan? Things like that. Self-funded, it gets a little more fun, or I think it's fun. Not everybody probably does. But there you really do have a lot of things you can do. So you can look at what are the primary cost drivers. So do we have an access issue within our population? So for instance, are members having an issue paying for their drugs? If that's the case, and they may not be taking them, which could be actually raising costs on the medical side. So one thing we'll look at is if that is the case, we may even suggest that you start paying for more medications on behalf of your members.
Mm-hmm.
So you would think, okay, hey, you want me to pay more money? How's that going to help me? But if you put in something, let's just say, for instance, you have a high deductible plan only. So everybody is in a high deductible plan. They're paying for the high cost of those meds up front. Maybe you look at something like putting in that expanded preventive list. So this is outside of ACA.
Yep.
You put in an expanded preventive list. You can do it brands and generics. You can do just generics. But either way, and oftentimes you will see sometimes just easing that access point for members, they will increase their adherence to their medications, which will then save you money on the medical side. Now, in terms of actual savings on the pharmacy side, I don't like to mess with copays too much, just simply because in the grand scheme of things, if the medication is $500, we're not saving a ton by increasing the member copay $5.
Right.
But at that point in time, especially on a specialty med, right? So if the med's $6,000, we raise the copay $100.
What's it going to do?
A copay
Right.
card. Exactly. It's not going to prevent them from being a stop-loss hit. That $100 per month. So something we'll do is we first look at their utilization management. So do they have members accessing drugs without the proper prior authorizations and step therapies? Is there something we can do on quantity limits? We will also look at, my bread and butter is formulary management.
Mm-hmm.
What kind of meds are your members taking, and are there clinically appropriate, equally,
Effective,
clinical significance that may have a cheaper price tag that we could shift members to? Mm-hmm. And then finally, looking at something called alternative funding. So especially carve-out is something we've had a lot of success with.
Yep.
It's not right for everybody, but I do think in instances where you can use it, and we're at a point now where it's not even, everybody has some sort of alternate funding solution. I think it's important how you do that alternate funding, how you structure your contracts with your PBM, because there are ways and times out there that maybe doing alternate funding, if you're in a PBM contract where, for instance, you forego rebates if you do alternate funding, or you forego prior authorization criteria, you're not going to come out better in the long run. So it's all about how you set that plan up on the front end.
And negotiate that
those
contract.
Are different things we've done.
Yeah.
Yeah, absolutely. Those are some things we've done for clients that has really driven some cost savings for them.
And you mentioned it, talking about savings for the participant and kind of we as consumers. I think about there's two primary types of plans from the consumer standpoint. One would be a copay plan. You've got a generic and a brand and non-formulary. Then the other, it would be with a high deductible plan where, the contracted price is the contracted price when you hit the pharmacy. But what are some of the things that we can all do? Is it, going to the manufacturer's website and getting a coupon, or shopping around? How do you really effectively do that as a consumer, in your opinion?
No, I think that's a great question. So I think the first question is always at the prescribing point. So asking your physician, is this a generic? If it's not, is there a generic available that might be better? That is one thing I've noticed is just honestly prescribers, they're not as familiar with the cost of medications. And so oftentimes they're even a little sticker shocked. Like when they go, we work with several hospitals, lots of physician groups. They're even a little shell shocked when they get to the pharmacy counter and they're like, oh, I didn't know that's what that cost. Yeah, exactly. So, that's the first thing. And the second thing is, if you have to take a brand name, yes, absolutely, there's always a coupon. And so for the patient, that's definitely something you want to check out. Oftentimes, prescribers or pharmacies may have those readily available. You can actually normally go to the pharmacy or to the manufacturer website. So, for instance, if you go to Wegovy.com, just since we were just talking about that one, there's always a patient savings and support section at the website. And then the other thing would be, especially with generic medications, because that is where the biggest fluctuation in cost can be. Highly recommend shopping around. And I don't say that in a way of, I don't want you to use 5 different pharmacies if you have 5 different medications. But most PBMs have a website that will allow you in a member portal or something such as that to go in, put your medications in, look at what they cost at different pharmacies, pick which one works best. I mean, one drug may be 5 cents more expensive at one pharmacy, but the other may be $10 cheaper at another pharmacy. And so just find that pharmacy that's the best fit and make sure that you really are saving where you can, and in a way that's convenient for the member so you still take your drug.
Yeah. Yeah, that makes sense. And I don't know, last question here, if you have the data, or this is just my suspicion, having been on both types of plans, where in a copay plan, if the difference between a generic and a brand copay is $20, like a generic is 10 and a brand is 30, I think a lot of people just go for the brand, as opposed to being on a high deductible plan like with an HSA, and you go in and you say, okay, well the brand is $150, but the generic is $3. Most people are going to gravitate towards the generic in that particular case. And I would have to think that element of the consumer-driven aspect of the plan probably plays out in real life on the claim side. But do you guys see that data, or do you have an idea of the difference that kind of copay differential drives?
So that's a really interesting question. One thing I will tell you, most clients we look at now have a really high generic utilization rate. Most clients I see run about 88 to 90% generic dispensing rate, or GDR is kind of what we call it. So right off the bat, when you're looking at that percentage of drugs or generics, that's already a big chunk of it, right? In instances where a generic may be available for a brand name. So for instance, let's say we're talking Crestor and it's generic rosuvastatin.
Yep.
In plans such as that, I actually set my plans up to where a member they don't want to get the brand. So we want to ensure that they're taking the generic when it's available.
Yep.
And so what we'll do is we'll essentially set them up with kind of a brand penalty copay if the member chooses to take that brand over the
right. Sure.
Yeah. So essentially what that'll do is it'll charge the member the flat copay that they would have paid for the brand, and then the difference in cost between the brand and the generic.
Yep. And that's an eye opener.
Exactly.
That'll change behavior.
Oh,
right.
That changes behavior very quickly. And then the other thing, obviously there's always going to be a few things. I can't think of very many off the top of my head. But there are a class of medications kind of called narrow therapeutic index drugs, where if you start on the brand, they really prefer for you to stay on the brand, just because even the slightest change in chemical makeup
can throw you off. Yeah.
Absolutely. So in those instances, obviously, there are medical exceptions to that. And so you can set the plan up to where if the physician requested the brand, it won't charge them a penalty.
Sure. Right.
Yeah, absolutely. And so that can all be done at the pharmacy counter and between your plan billed on the front end. We refer to those as dispenses written, or DAW codes.
Yep.
You can set something up on the front end, and then also, that way the pharmacist can put it in right there on the front end of the pharmacy counter. There doesn't have to be any kind of exchange of info between the physician, the pharmacist, and the PBM. It just happens automatically.
Yeah, that's great information. Good, really good to know. Well, Geri Beth, I don't know how many people would say that talking about pharmacy spend is a delight, but this has been a delight, and I really do appreciate the time.
Well, thank you.
And if I'm, when I reflect back on the conversation here, there's kind of 3 things that stand out to me. One is, if you are a decision maker at a fully insured company, there may be circumstances that prevent you from going self-funded, but don't feel helpless, right? There is a way to get the information and then use that to your benefit in the negotiation process. So that's one. Two is if you are a larger self-funded employer, there's lots of levers that you can pull, but you really want an independent consultant, with your background and expertise that can help you wade through that and give really proper advice. And then number three, as a consumer, for all of us, making sure that we're shopping around, doing our best, talk to your doctor, talk to the pharmacist, and go to the company websites, both the manufacturer and the PBM portal or with the carrier that you're using to be able to shop around. Does that sound about right?
Yeah, you nailed it. Thank you so much. This is great. Thank you for having me.
Yes, thank you. Really appreciate the time. We'll talk soon.